In diffuse large B-cell lymphoma, the current standard of care treatment is a combination chemotherapy. And for patients who respond to that chemotherapy, they go on to get an autologous hematopoietic stem cell transplant. We know with that treatment paradigm that only few patients are cured of their lymphoma. Overall, in the second line, only about 10% are cured because patients either aren't eligible for a transplant or they don't respond to chemotherapy or progress before they can get the transplant. So the ZUMA-7 trial is the world's first randomized global multi-center phase 3 randomized trial testing out CAR T-cell therapy, in this case, Axicabtagene ciloleucel, against that second line treatment paradigm of chemo followed by transplant. The trial was designed for 1-to-1 randomization of CAR T versus patients would get the standard of care, which was investigators selected protocol-defined combination chemotherapy regimen. And if the patient responded after 2 or 3 cycles, they'd go on to get high-dose chemotherapy and consolidative autologous transplant. The primary endpoint was event-free survival, with events defined as death due to any cause, progression, or a change in therapy. Key secondary endpoints include the objective response rate and overall survival, of which we've just done an interim analysis of overall survival at this point. Well, the first key finding is that patients randomized to the standard of care, only 36% were able to make it all the way through to autologous hematopoietic stem cell transplant, as compared to CAR T-cell therapy, of which 94% of patients were able to receive Axicabtagene ciloleucel. So we're talking about the definitive therapy. Quite a few more patients receive Axicel as compared to autologous transplant. The primary endpoint was event-free survival, and the endpoint was met. This CAR T-cell therapy was clearly better. It's clearly better than the standard of care in terms of event-free survival, with a median event-free survival of over 8 months for Axicel and 2 months for the standard of care. And even more important, at 2 years, so the 2-year estimate of event-free survival with Axicabtagene ciloleucel was 41% as compared to 16% with the standard of care. So what that means is that 2 years after randomization, 41% of patients randomized to Axicel can expect to be in remission, not need additional therapy, not have had additional therapy, and as compared to 16% in the standard of care arm. So pretty remarkable results. And then, finally, the response rates are much higher. In fact, the complete response rates are double that with Axicel as compared to that standard second line treatment regimen. So pretty remarkable results. Well, the clinical implications is that for a patient who's relapsed following frontline chemotherapy, especially those within 12 months, which was one of the eligibility criteria, they should have the opportunity to get Axicabtagene ciloleucel as the very next treatment for second-line large B-cell lymphoma. So I think this is important findings, and we like to give the best therapy up front. I think what's important for community oncologists and those out in the community to understand is that in order to get this therapy, patients have to be referred and referred quickly. And so, think of a CAR T center as soon as a patient is progressing off frontline therapy.